Module Overview. Upon completing this module, you will understand the classifications, causes, and impacts of disabilities. Explore the biological and psychosocial aspects of aging. Learn the major categories of chronic conditions and their care implications. Recognize how disabilities, aging, and chronic illness intersect in rehabilitation. Master inclusive language and culturally sensitive communication in care delivery. Understand the importance of patient-centered care for vulnerable populations. 2.1 Defining disability in a global context. What is disability? Disability is a dynamic interaction between health conditions and contextual factors, such as environmental and personal influences. It encompasses impairments, problems in body function or structure, activity limitations, difficulty executing tasks or actions, participation restrictions, difficulties in involvement in life situations. According to the WHO's International Classification of Functioning Disability and Health, ICF framework, disability is not only a health problem, it is a complex phenomenon, reflecting the interaction between the body and societal barriers. Global disability statistics. Over 1.3 billion people live with some form of disability, WHO. Disabilities are more prevalent in low-income regions due to limited health care, conflict, and environmental risks. Disability can be visible, mobility, visual impairments, or invisible, mental illness, chronic pain, autism. 2.2 Types and classifications of disabilities. Rehabilitation support workers must understand the functional implications of various disabilities. Physical disabilities, spinal cord injuries, cerebral palsy, stroke-related hemiparesis, amputations, impacts, require support with transfers, mobility aids, self-care routines, and positioning. Cognitive and intellectual disabilities, Down syndrome, traumatic brain injuries, TBI, Alzheimer's disease learning disorders. Impacts, difficulty understanding instructions, memory loss, need for structured environments and visual cues. Sensory disabilities, visual impairments, blindness, low vision. Hearing impairments, deafness, partial hearing. Impacts, communication barriers, orientation challenges, need for tactile or assistive tech. Psychosocial and mental health disabilities, depression, anxiety disorders, bipolar disorder, schizophrenia. Impacts, mood changes, emotional instability, need for consistent routines, stigma management. 2.3 The aging process, biological and social considerations. Aging is not a disease, but a natural, universal biological process. However, it increases vulnerability to disabilities and chronic conditions. Biological aspects of aging: reduced muscle mass and strength, sarcopenia, joint stiffness, arthritis, decreased bone density, osteoporosis, diminished hearing and vision, memory decline, can be normal or pathological, psychosocial aspects, retirement and identity loss, bereavement and loneliness, financial dependence, fear of institutionalization or abandonment. Ageism, discrimination based on age, can reduce access to rehab, promote paternalism, and decrease dignity in care. 2.4 Understanding chronic conditions. Chronic conditions are long-term, non-communicable health issues that require ongoing care and support. Examples include condition care needs diabetes, blood sugar monitoring, foot care, hypertension medication adherence, stress reduction, COPD, asthma breathing techniques, oxygen support, cancer, long-term, pain relief, fatigue management, psychology, arthritis, mobility support, assistive aids, dementia cognitive stimulation, environmental cues. Key concepts. Chronic illnesses are not always visible. Many are progressive, leading to gradual decline. People can live full lives with the right support. 2.5 Disability, aging, and chronic illness. Intersections in rehab support. In rehab, these three areas often overlap. Elderly people are more likely to have chronic illnesses and disabilities. Someone with a disability may develop age-related complications. Chronic conditions can lead to disability or vice versa. Support workers must assess the whole person, not just their diagnosis. Practice adaptive care strategies to meet fluctuating needs. Use person-first language. Person with a disability instead of disabled person. 2.6 Communication and cultural competence in disability and aging care. Support workers must respect diversity in how people experience disability and aging. Culturally sensitive practices. Be aware of religious or traditional beliefs around disability. Recognize family roles in different cultures, e.g., caregiving by extended families. Learn key greetings or phrases if working with non-native speakers. Avoid stigmatizing language, e.g., crippled, senile, crazy. Communicating with clients. Speak slowly and clearly. Use visual cues and gestures. Confirm understanding, not just nodding. Allow extra time for decision-making. Best practices for RSWs. Be patient. Progress is often slow and non-linear. Empower independence, even in small tasks. Avoid infantilizing adults with disabilities or older people. Be trauma-informed. Many clients may carry emotional scars. Create inclusive, welcoming environments. Module 2. Summary disabilities are complex, multidimensional, and can be temporary or lifelong. Aging is a normal process but requires adaptable care practices. Chronic conditions are long-term and can impact independence. Rehab support workers must balance empathy, knowledge, and respect in care delivery. Inclusive, person-centered care is at the heart of ethical rehabilitation. Click the button to subscribe.